My name is Beth White, and I'm a Beacon Quality Improvement Coordinator. I am happy to be facilitating this call today. Our objectives today are to describe diagnostic tests that are used prenatally and postnatally to identify neonatal abstinence syndrome, and to discuss practice-based implications of legalities in drug screening and testing for prenatal drug exposure. Our first speaker is Dr. Maura Crowley. She's going to address maternal and infant screening and testing for drug use. Dr. Crowley?
Good afternoon, everybody. So we want to set the stage today and discuss screening versus testing. The language is very similar and tends to be used interchangeably, which can lead to some confusion. The American College of Obstetrics and Gynecology recommends that every woman is screened at the beginning of her prenatal care with a questionnaire. This questionnaire is then used as a risk assessment for the use of alcohol, tobacco, or other drugs. And then a subset of women should be tested. It should be those women who have a positive screen for these possible risks, or be tested if there is a limit for a limited set of behaviors, such as not receiving prenatal care or that she shows up and appears to be intoxicated. So screening for drugs of abuse, the best practices. So again, according to the ACOG, we want to screen everyone with a short questionnaire, which is asked at the first prenatal visit and on admission to labor and delivery. Each hospital should have a standard policy that applies to all admissions and that specifies triggers for sending a maternal drugs test. It should specify historical triggers such as no prenatal care, a prior positive toxicology screen, and or observed behaviors that will lead to a screen. There are some that advocate universal screening or testing to everyone to prevent some biased assessments and discriminating against one class of person. And what is most important is that every person should be informed if a test is being sent. So what maternal toxicology testing options are there? Urine is the most rapid screen, and they are done using immunoassays, which means that a fluorescent tag reacts against the substance of interest in the patient's urine. The advantage of a urine toxicology screen is that it's fast and relatively inexpensive. However, it does have some disadvantages. First, it only detects exposures in the prior 24 to 48 hours. And then all positive screens require confirmation with gas chromatography mass spectroscopy. So this is needed, and you need to find out that if this is done automatically by your lab or if it needs to be a separate order after a positive screening test. And there are false positives and false negatives. So what causes false negatives? So if a urine is too dilute, and unfortunately there are deliberate attempts to adulterate the test. Some people add nitrates or Visine to their urine test, or they can use a quote-unquote clean urine, so somebody else's urine, or diluting it down with water or just submitting tap water. There are false positives, so the immunoassays can react with similar molecules. And then infant urine actually has higher false positive, especially for marijuana, than adults. It's because their urine is relatively more dilute, and there's more protein in infant's urine. Amphetamines have the highest false positive rate of up to 4%. PCP also has a high false positive rate of 1.5%. And also need to know that opiates can cross-react with certain antibiotics, levofloxacin being the one that's most often implicated. And then just to illustrate how different substances can cross-react to similar molecules on an immunoassay, we can see here that in the top left, there's a molecular structure for phencyclidine or PCP. And if you look to the right of the top right, the structure of dextromethorphan is very similar to PCP and actually can cause a false positive on a drug screen. And down below, you can see that meperidine, ketamine, and ibuprofen also have similar structures and then can cross-react with each other. So sometimes we have to be suspicious for a false positive, especially when the story doesn't necessarily fit the test results. And then when we look at testing newborns, there are several options: urine, meconium, umbilical cord samples, hair, nail, and vernix. However, none of these is a perfect option. The two most common that we use are urine and meconium. But urine may be difficult to collect, and it reflects a relatively short window of exposure in the order of days. Meconium may be difficult to collect because of delayed passage, especially if it's a preterm infant. However, it does reflect months of in utero exposure, so it gives us a better picture of what the infant has been exposed to. However, it has high false positive rates, especially for opiates, with only 59% of the positive screens of meconium, which are then confirmed by GCMS. So unfortunately, none of our tests are perfect. And what I'm going to talk about now is what we do at Rainbow Babies and McDonald Women's Hospital of our approach to women. So as I've said before, the ACOG and the AAP recommend against universal toxicology testing, but screening is an essential part of complete obstetric care. Ideally, this should be done pre-conception and as well as early in pregnancy, and it should be done on every woman. So we want to make sure we ask all patients. It's actually important to disclose to women that we are asking everyone so they don't feel that they're being kind of called out on it. We want to do this in a non-judgmental manner. We want to make sure that they realize that this is confidential. It's going to be kept between her and you. And we want to assure her that we're asking her this because we want to be able to provide adequate care for both her and her developing fetus. And we want to make sure we talk about and ask about illicit as well as prescribed substances. So there are several tools out there as to how to ask. These are just 3 examples. The references are down at the bottom of the screen in case you want to read more about them. The first tool is called the 5 Ps, and it consists of 5 questions that all relate around something that begins with the letter P. So you want to ask openly about the patient's parents' use of alcohol or drugs or tobacco, and ask about her peers, her partner's use, her past use, and then her use pre-pregnancy. There is also the CRAFT questionnaire, which is actually designed for late teens to early 20-year-old women, so 16 to 26 years old, and it's 6 items that ask about the use of substances or concerns about using substances. And then a third example is the SERPI, which is the Substance Use Risk Profile Pregnancy Scale, and it asks about how much alcohol and tobacco use in the past month prior to pregnancy, and it consists of 3 questions. So a lot of these tools consist of easy questions to ask. There's very few questions, so it can be done quickly, and so you can get a good idea whether the woman is at risk and needing to go on and further test the infant or the mother. So at McDonald House, our approach is to ask all women screened early and when they arrive onto labor and delivery. Our general admission consent does include consent for testing, but we must disclose to a woman that the test is being sent, and she can refuse. So when do we send a test on a woman? So we send a test anytime that we have a positive screen, anytime that the woman has had a positive toxicology test in the past 2 years, if there's been a referral from an outside social service or from our own social work, and if there are the other clinical indications such as no prenatal care or if she arrives intoxicated or high. So when testing is indicated, we need to document the indication and disclose this to the mother. She can decline the urine testing, but if she does, we document that, and then the OB team is actually very good about discussing that with the pediatric team so that the pediatric team can then monitor the infant and send testing on the infant. So we also have a policy of when we send urine testing on infants, and we do that when the mom declines testing and there is a concern, or if the mother has had a positive toxicology screen, or if the infant exhibits any signs or symptoms of withdrawal. This is all well and good. We don't universally test every mom. So are we missing babies that we didn't know mom was using a substance and she passed all of our screens. So kind of looking back at this, look to see if we had any readmissions from the nursery. In the past 6 months, we have not had any readmissions for symptoms relating to neonatal abstinence syndrome. So it seems that we're not missing babies thus far. And I think now Dr. Wexelblatt is going to talk about universal testing.
Mercy Anderson Hospital does around 2,000 deliveries a year. As you can see from this graph, they were having a higher rate of neonatal abstinence syndrome and drug exposure, and they seem to have a higher severity with more babies need to be treated for their withdrawal than the Cincinnati region as a whole. We felt like they needed to go ahead and look at a better way to identify babies prior to being discharged. So in place, we had a maternal risk-based screen that if you had a positive screen, like Dr. Crowley was saying, we'd go ahead and then test the mother. Our previous screen was a little different, and legal reviewed it, and we talked about going to doing universal testing and realized that what we had as our previous screen may have been considered as profiling. Our general consent does state that we're going to be doing laboratory testing on admission and felt like it'd be worthwhile doing a 6-month trial that then got bundled up to a 18-month trial to see what we found when we went to universal testing. So next slide will show you, it's a little complicated, but I'll walk you through it. So on the top, you can see that we had 3,000 moms that came through during this 18-month period, and we were able to capture 2,956 of these, with 38 not being obtained due to precipitous deliveries, emergency C-sections, or just not being part of the process initially. We missed some. And we only had one mom refuse during this period. If you then go down to the next column, you can see positive urine drug screens. We had 159 tests that were positive on these moms, which ended up being 5.4% of all the moms that showed up to the hospital to deliver. And then we broke down those 159 tests and looked to see who was positive for opiates and then positive for other drugs. But our main area that we wanted to look at was the positive for opiates. So we needed to try to identify these babies born to these moms that were positive to opiates prior to discharging them. We have a bundle in place that we observe all positive opiate-exposed infants for 72 hours for opioids, and that we go up to 96 hours if that opioid is methadone or buprenorphine. So we looked at all the positive UDSs, all 159 charts, and looked to see if these moms would have been tested in our old system, meaning they had to have a positive screen to be tested. And what we found out on the bottom row, you can see the total number of positive tests with a negative risk-based screen was 23% of all of our positive drug tests, meaning 36 of these 159 tests, these moms would not, their babies would not have been identified because we would not have obtained a test on them because they had a negative screen. But the most important group that we wanted to look at was the opioids. Those opioid-exposed infants whose mother had a negative risk-based screen. And you can see that of all the moms that were positive for opiates, only 20% of them actually had a negative screen. And then we followed those 19 infants. In the bottom left-hand box, you can see the number of negative risk-based opiate-exposed infants needing a change in their care, an increase in their care due to increased Finnegan scores. And we found out that 7 of those infants needed to be admitted to the special care nursery, and 1 needed pharmacologic treatment. So once we were able to see that we were missing quite a bit of opioid-exposed infants with moms who didn't meet the criteria to obtain tests in our previous screening system, we felt like we needed to go to universal testing in our area. So we got together with the Greater Cincinnati Health Council and wanted to involve all of our hospitals in the region, which is the next slide. And you can see them here. We all decided to go together at the same time because we didn't want families to say, well, I'm going to go to this hospital because they're not doing universal testing. We wanted to make this, the whole rationale behind doing universal testing is not punitive. The whole rationale is to identify patients, infants exposed to opioids, so we can observe them in the hospital so they don't withdraw at home. we did go through the Greater Cincinnati Health Council to change our consent and to put it into general wording for families. We also realized that we hadn't been consenting for syphilis testing, which all the moms were getting on admission to, and we don't really talk about the CBC or the blood type and screen that all the moms were getting obtained also. So we changed our consent, and we, on positive tests, we have a process in place that the OB will go talk to the mom, see what type of help that she needs and is willing to accept, and to see if there's anything in her history that may explain a possible false positive. I think I'll turn it over to Beth to go over this poll question.
Thanks, Dr. Wexelblatt. We've got 3 poll questions. This is where we would like you to participate. The first poll question, I will read to you. I'll read you the questions, and then you will see where you can click. OPQC Central is going to put up some buttons that you'll be able to push so that we can find out just what the audience is thinking about these questions. The first is, do you have a policy for screening pregnant women for drugs at your hospital? Your choices would be yes, that you screen all pregnant women for drug use. The second is yes, that you screen, but only with a history of drug use. The third is no, you don't screen pregnant women for drug use. And the fourth would be if you don't provide care for pregnant women, this question would not be applicable. So please vote. Let me know how we're coming along, Jessica, with the percentage who have voted.
You're at 77% right now, Beth.
Ooh, that's great. Okay, let's see what the results are. Okay, 54% do screen all pregnant women for drug use. Screening only with a history of drug use is a little bit over a third. And 8% of you don't care for pregnant women, provide care for pregnant women. Thank you. Okay, good. Let's look at the second poll question, please. Okay, now we're interested in looking at whether or not you have a policy for testing babies at your hospital. Yes, you do test all babies for drugs, or you test only babies that have a maternal history of drug use, or no, you don't routinely test your babies for drugs. So please vote. Okay, 86% of you only test babies if there's a maternal history of drug use. 5% test all babies, and 9% don't routinely test babies for drug use at your hospital. Important information. Thank you. Could we look at the third poll, please? Okay, we're looking at policy. Do you have a policy for testing mothers at your hospital? And the choices you would have are yes, that you test all pregnant women, that yes, you have a policy that says that you will test only pregnant women who have a history of drug use. The third is no, that you do not have a policy about routinely testing pregnant women for drugs, or that your policy says that you do not routinely test pregnant women for drugs, or it's not applicable to your practice setting. So again, here we're looking at not your practice, but your written policy. Okay, great. Let's see what the results are. Okay, 38%, pretty split. The written policies in 76% of hospitals, specifically about the policy of testing women. 38% of you have a policy to test all pregnant women, and 38% of you have a policy that says you only test pregnant women who have a history of drug use. 17% have a policy that does not address routinely testing, and 8, again, are not applicable. Okay, next slide, please. These results of the polls, I'm sure Dr. Wexelblatt will be addressing in this next section, because those poll results give a really good perspective to the second really big topic that we're going to talk about this afternoon. Dr. Wexelblatt will continue to talk with us about the discussion on legal implications for drug testing in Ohio. Dr. Wexelblatt?
Thanks. Next slide. So all of these slides are produced by Dr. Faneroff up at Rainbow Babies in Case Western. So the next slide should actually show there is a huge disclaimer because I am completely stealing his information, and I've stayed at a Holiday Inn, and that's the closest I'm going to become to being a lawyer. So next slide. Like I said, this is his presentation, which was excellent, and I wish he could be here to give it. So the AAP has noted that there are multiple issues on whether to use biological specimens to screen for drug abuse. These issues are whether to screen the mother, her infant, or both, and which women and which infants to screen are issues. And these are all complicated by legal, ethical, social, and medical concerns. And the whole question is, what is the right of the mother versus the right of the child? Talks about the U.S. Constitution, which we need to address anytime we talk about law in this country. So if the law is a set of rules we live by, then the Constitution is the highest law. It created our government and discusses how the government should work. Each state has its own constitution, which sets out the highest laws for that state. Shows that the Constitution adopted in 1788 set up the structure for government, but had basically no guarantees of individual freedoms. So 3 years later, 10 amendments were added to the Constitution, and this is what is known as the Bill of Rights. The Bill of Rights contains the fundamental rights and freedoms of every citizen. When we talk about patient rights, the most important document is the Bill of Rights. Because the Bill of Rights gives power to fundamental bioethical principles of autonomy, autonomy is the concept that a competent adult has the right to choose and follow their own plan of life and action, including determining what happens to their body. The Supreme Court has recognized that under the Bill of Rights, competent persons must be informed about their medical care and have rights to refuse medical treatments. But these are the other ones listed in the Bill of Rights. So Justice Cardozo of the New York Court of Appeals noted in an important case against a New York hospital stated, every human being of adult years and sound mind has the right to determine what shall be done with his own body. So the only other, the Fourth Amendment is the second most important amendment to talk about, as this protects individuals against unreasonable search and seizure. And it, as you can see, it's stated there it talks about the search and seizure. The U.S. Supreme Court considered whether a program that utilized drug tests in pregnant women either violated the Fourth Amendment, and this is a case of Ferguson versus the city of Charleston. So this case happened at the Medical University of South Carolina. This was happening during our crack epidemic in the early 2000s. They started a testing program referring to counseling, but they showed that there was no change in the incidence of their mothers utilizing cocaine. So they began to work with law informants, and a new program was implemented. And so what they started to do was test women if they had poor prenatal care, had a history of infants with birth defect or poor fetal growth, had a history or had a placental abruption, had a history of drug or alcohol abuse, or if there was intrauterine fetal demise. And under the new program, women were immediately arrested if they or their newborn tested positive for cocaine. One woman had to spend the last 3 months of her pregnancy in jail. Another woman was arrested shortly after birth and still dressed in her hospital gown. The prosecutor, after a year, decided to add an amnesty component to the program, giving the women the option of going into treatment to avoid arrest. However, if they failed to complete the treatment program or tested positive second time, they were then arrested. So 30 women alleging that the program violated their Fourth Amendment brought their case to court. And the final opinion by Justice Stevens ruled in favor of the pregnant women, stating that their reasonable expectation of privacy enjoyed by the typical patient undergoing diagnostic testing in a hospital is the result of those tests will not be shared with a non-medical personnel without their consent. So this next slide shows that while the Ferguson case is very significant, many pregnant women continued to be arrested and charged with a variety of crimes for using drugs during their pregnancies. And these include felony child endangerment, corruption of a minor, chemical endangerment, assault with a deadly weapon, or even delivering drugs to a minor, claiming that the drugs were transmitted from the mother to the infant while the umbilical cord was attached. So this does not mean that parents are free to do whatever they want. Children are not property, and the government does have the power and the duty to protect the safety and well-being of children. So this is known as the doctrine of parens patria, which I never took Latin, so I probably butchered that, which is Latin for parent of the nation, and the government has a duty to protect these children. So the federal government has developed the Child Abuse Prevention and Treatment Act, CAPTA, and this provides federal government to the states, and it defines child abuse and neglect as any recent act or failure to act on the part of the parent or caretaker which results in death, serious physical or emotional harm, sexual abuse or exploitation, or an act of failure to act which presents an imminent risk of serious harm to the infant or child. It also states that health care providers must have policies and procedure in place to notify CPS of all infants born and identified as affected by illegal substance abuse, withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol disorder, and to establish a plan of safe care for these newborns. Results of prenatal substance exposure shall not be construed to be child abuse or neglect and shall not require maternal prosecution. So it is important to remember that the primary responsibility for both medical practice as well as child welfare services rests with the state. Each state has its own legal and administrative policies and procedures that addresses the need of children and families. States vary widely on their approach to pregnant women who utilize drugs. One state allows assault charges to be filed against a pregnant woman who uses certain substances. 18 states consider substance abuse during pregnancy to be child abuse. 15 states required healthcare professionals to report suspected prenatal drug abuse, and 4 states require prenatal drug testing for suspected abuse. So Ohio's approach has been described as enlightened, as substance abuse during pregnancy is not automatically considered a criminal act or child abuse, and there is a $4.2 million 3-year targeted drug treatment program for pregnant women, which is supported by the Ohio Department of Health. So to emphasize key points to respect to drug testing, care should not be based on which healthcare provider is on call. We need to have a policy to be in place and to be followed consistently. Hospital counsel should be ensured the compliance with state and federal laws. Maternal infant drug testing should be based on specific evidence-based criteria and medical indicators to avoid discriminatory testing. Open-ended criteria such as clinical suspicion are not adequate. All mothers should be informed about proposed drug testing prospectively, and the rationale for testing should be documented in the medical record. The discussion should include the nature and purpose of the test and how testing will guide care for the mother and or infant. If a mother refuses testing, document the refusal and do not test over her objection. When medically necessary for the proper and safe care of the infant, testing may be done without informed consent of the mother. This includes newborns who exhibit signs and symptoms of drug exposure, newborns whose mothers have been identified as probable substance users, and newborns whose mothers have signs and symptoms of drug use. Remember that under Ohio law, all healthcare providers are mandated reporters of child abuse and neglect, and we are required to report when there is reasonable cause to suspect that a child has suffered or faces a threat of suffering any physical or mental wound, injury, disability, or condition of a nature that reasonable indicates abuse or neglect of the child. So I'll turn this back over to Beth before we go into questions.
Sure. Thank you, Scott. The law is complicated, isn't it? It's both specific and open to interpretation. Over the last 40 minutes, we've covered a lot of important information, some of it controversial. The polls show that there are different approaches to this issue of testing mothers and infants for drug use. We want to hear from you at this point. What methods do you use at your hospital, and why was this method chosen? Have you had challenges regarding maternal screening or testing, and if you have, how did you overcome them? If you have questions or comments, please press *6. That will take you off mute, and we'd like to find out what you think. Right, Scott and Maura? They're ready to answer your questions. I think Dr. Michelle Walsh is on the phone as well. She is the clinical lead for the Neonatal Abstinence Syndrome Project at OPQC. And the quality improvement lead, Susan Ford, is on as well, who can address some of these questions. So what do you think? *6.
And if you don't want to come off mute and rather type in your question, that's another way to get a question to us, and we can read it for you.
That's exactly right. Thanks for reminding me about that. On the right-hand side of your screen in the chat box, you can type in your question if you'd rather not speak it out loud.
I have a question. This is Dina Stewart from Hillcrest Hospital. Concerning prenatal visits, so when we're talking about insufficient prenatal care, is there a certain number of prenatal care visits? In our policy, it currently states less than 3 prenatal visits, but it sounded like in the webinar it was care that started after 12 weeks gestation.
That was just what that one hospital had, and I think if you go to the definition of limited or late prenatal care varies in the OB literature. I think the most important thing is having a policy and sticking to it. So whatever you guys define as what you want to define with your obstetric colleagues as what is considered insufficient prenatal care or late prenatal care, as long as you have that in your policy and you're consistent throughout, that's the most important thing in my opinion.
Okay, thank you.
Yeah, I would agree with Dr. Wexelblatt that, it's what you determine at your institution. And as long as you're applying that equally and fairly over to all women, I think that's the most important part.
Just one more question. When there's history of alcohol and drug abuse that we have on our questionnaire, how far into their past, because it sounded like, according to the webinar, it was approximately 2 years. What if they had alcohol or drug abuse, 10 years ago?
So I think so you're reminded these are just screening questions, and so I think once you ask these screening questions, and then if there's something that kind of sets up a red flag, then you can delve more into and ask more specific questions and determine, oh, well, if she had an alcohol abuse problem 10 years ago and now has been in remission and doing well, then I think that maybe not necessarily need to send testing.
Okay,
but,
thank you.
Great questions. Jess, do we have any questions that have been written in?
As of right now, we do not.
Okay, thank you. *6 will take you off mute, and the doctors are here to answer your questions. And we certainly welcome your comments about this topic as well.
This is Dina from Hillcrest again. I have a question about the history of alcohol abuse. What kind of process do we have in place for screening that? I mean, what would you recommend? I guess that currently, we can screen for we screen for both, but testing of alcohol abuse?
Yeah.
So
I think
this is Michelle Walsh. So is your question specifically about testing for alcohol abuse, not screening?
Yes, I'm sorry. I get a little confused with that.
Yeah. So most people, because alcohol's half-life is so short, the only test that would be available for that would be a blood alcohol level, which would only be helpful if the person appeared intoxicated.
Okay, that makes sense.
So there's no other test that would give you a longer profile of alcohol exposure.
Right. Yeah, there's just a lot of screening questions, and a lot of the screening questions are built around alcohol use. There's like the CAGE questions, which talk about, have you feeling guilty? Have you tried to cut back? Have an eye opener so it can get around how much her use is. But yeah, there's really no testing except for a blood alcohol level.
Thank you.
Thank you for your question. It's a quiet group today. It looks as though there aren't any more questions or comments. Would the faculty agree?
That sounds right.
Yes, that's
Okay, good. Thank you, Dr. Wexelblad and Dr. Crowley, and thank you everyone who has been on the call. Your time and interest in this important topic is appreciated.